Right, it's a couple of minutes past 1 and I can see about 18 people on screen, so I think we'll get started. Welcome everybody to Grand Rounds. My name is Leslie Crichton, and today we're bringing you a Global Citizens Tayside edition of Grand Rounds, so a slight hijack and just a little introduction to Global Citizens Tayside for those of you who haven't encountered us before. We're an interested group of people from NHS Tayside and from the University of Dundee, and our aim really is just to share the fantastic global citizenship work that is going on in the area that people may or may not know about, and to support each other. And we do that via some regular hijackings of Grand Rounds, but we also have some social media communities as well. So if you haven't already, please come and join us on Facebook and on Twitter. So today we're delighted to have Rosemary Mugwe in Nairobi and David Cunningham a little bit closer to home from a charity that's got some very local roots to talk about transforming access to essential and emergency surgery across Africa. So Rosemary is a lawyer by background with an advanced degree in development, and she has over 15 years experience of working on health development initiatives. And David is a graduate of our very own University of Dundee and a former president of the Dundee University Students' Union, or Association, is it, Dave?
Yeah, association.
And some of you may recognise him from his previous time as chief exec of the Archie Foundation, which is another charity that has roots very close to home. So without further ado, I'm going to let them both tell us more about Kids Operating Room and their work.
Thank you very much. Well, I will go first, welcome. Can I just ask, can you see my screen? Is that okay?
Yep, we can see.
Great. Well, thank you, Leslie, for that introduction, and thank you for having us here today. It is my great pleasure to really introduce Rosemary and to just set the scene a little for what she's going to talk to you about. As you mentioned, Kids Operating Room does have very strong links to Dundee. We have a huge warehouse and global operations centre on the Kingsway, and from Dundee to every country that we work in goes all of our equipment, and many of our skilled people head out from Dundee too. So we're extremely proud of that, and it really is wonderful to be here with you today. In the next 8 minutes or so, I'm going to try and do something that should take about 4 years to cover, but I'm going to try and quickly understand scale, talk about history and why it matters, talk about politics and why that matters, talk about geography, and talk about other barriers to care and why, at the end of the day, we think strengthening the system is the right thing to do. If I had time, I would love to talk to you as to why 40 years after Band-Aid, we still sing that awful song on the radio. Yes, they do know it's Christmas. The lyrics are just truly awful, but we don't probably have time for that today. So I will start with scale. If you haven't been to Africa, it is huge. And I think this image is just such a great indicator of just how huge it is. All of these major countries fitting comfortably inside it. And I think people don't necessarily recognize that, particularly the first time they go. And so it's important to understand that what might work in one corner isn't necessarily going to work everywhere else. And when it comes to actually understanding, well, what will work and how do we make useful interventions in healthcare, it's probably necessary to go back and actually just spend a minute looking at history. And I'm going to go from the right and work back in time, because global health is what we have now, and that striving for universal health coverage. But global health came out of something that was much more commonly called international medicine. And there it was all about vertical interventions. So focusing on trying to eradicate TB, eradicate malaria, or smallpox, the latter being successful, but not at all thinking about strengthening the wider system, just focusing on achieving particular goals. International medicine that existed right up until the post-war period was predated and evolved out of tropical medicine. And that is where the creation of the other first came into medicine. That is a problem for them, not for us. This is the creation that somehow they're different from us, they're other from us. And what's really interesting is that we assume, so going back sort of Victorian times now, we assume that that's something in the past. But when the pandemic started spreading around the world earlier this year, and when it reached Italy, and Italy became overwhelmed by the pandemic, you saw those views on health re-emerging. People in the UK saying, oh, that's Italy though, somehow that's different, somehow that's not as good as us. And that really comes out of tropical medicine. That's where that really started forming. And tropical medicine, sadly, was just an evolution of colonial health. And the first interventions in healthcare, particularly in sub-Saharan Africa. And those were the focus of keeping a workforce alive, so they could either be sold as slaves or forced to work in the mines. And when we come all the way back to global health, it is important that people going to work in global health recognize that what they are often dealing with is a legacy of our own ancestors' interventions that were not often for the right reasons. And I think that history is important because it changes the way you address the topic, it changes the way you speak to people when you're there. So history is important, but politics has been hugely important. And by this, I don't mean the politics of individual African nations. I mean the politics of the West. So in the late 1970s, the view was health for all. That was the goal. And you can look at these different initiatives, but the goal was health for all. Just before Thatcher came to power, before Reagan came to power, that was the approach. But then those two leaders came in and dominated politics in the Western world for a significant amount of time. So by the time the late 80s had come around and the Bamako initiative, the focus was much more on how the economics of healthcare. How do we introduce or how do we turn healthcare into an economic activity that can then be self-sufficient, was the theory, but actually that Western companies can then intervene in and profit from. And so user fees were devised and pushed by many, many organizations as the solution to healthcare in Africa. That would create a market. It would tick all of the boxes. And it was completely separate from the fact that nobody could afford them. And so what happened was we create a user fee system in countries all over Africa where health is no longer free at the point of access, and the vast majority of the population can't afford it. And that is still the norm in large parts of Africa. So this picture that was taken in Burundi is part of a malnutrition monitoring program. This child will be vaccinated as part of a vertical intervention program, most likely by UNICEF or somebody like that. But because the healthcare system is completely weakened and because the family can't afford the user fees, if the child then goes on to have appendicitis, they will most likely die, because that is the reality, is there's no way for this family to afford to pay user fees for care. And that's the irony of this situation. And if we stay in Burundi just for a minute, that's where we start to realize that geography is hugely important to understand as a barrier to accessing care. In Burundi, 87% of the population live in rural dwellings, and the country has extensive highland regions. And particularly in those highland regions, there are very limited roads and certainly no paved roads. And so that can mean that actually, even if you can afford the user fees, you might be 5 or 6 days away from a doctor who can care for you or for your child. And this picture was taken earlier this year. And if it is raining heavily, then that journey becomes basically impossible. And so these are barriers out with your control as an individual that are severely limiting your capacity to get care. And there are many others. And they tend to be classed as structural violence because they are essentially inflicting violence on you because they're stopping you getting care. And they range from strong pressure applied to particularly young mothers if their child is born perhaps with an anorectal malformation, will be to go to the local witch doctor, maybe give them all of your savings, limited as they are, or give them your livestock in return for care, which of course doesn't work. And that can lead to severe pressures to abandon children. And it can even be the husband who doesn't want to be seen to have produced a child who isn't perfect. And so pressure on the mother to abandon a child. Or in the north of Uganda, what they say is we gave the child back to the Nile. So a child's born with some sort of malformation. It is easier, and there is so much pressure on the family that is easier for them to literally put the child in the river. And I've seen that in different parts of Africa and Latin America, the same thing happening. And then when you add in the political tensions that exist, and we see in Ethiopia just now, or in Burkina Faso, where this picture was taken, and you see actually increasing challenges and barriers to accessing care. And so coming up with a plan to go to Africa for 2 weeks to do this one particular thing and then go home, which was the old mission model of care, just doesn't fit the bill anymore, I'm afraid. And I think that in reality is if that model was going to work, it would have worked by now. So the only long-term plan then seems to be that actually we need to stop doing that, and we need to strengthen the healthcare system. We need to finally recognize there are no others in health. We're all just humans, and we're all trying to do the same thing. And I think we need to recognize there is an amazing healthcare workforce in Africa. And as one surgeon put it to me recently, they don't need us to do their jobs. They just need a helping hand to get going. And I think that this picture on the right here is the great example of that. So when we first went to Uganda, which was 6 years ago, there was one pediatric surgeon, and he didn't have his own operating room. He had essentially nowhere to work. 6 years later, there's 5 dedicated pediatric operating rooms in Uganda, and there are 8 surgeons working there, all Ugandan, and they have a training program coming through as well. And that meant that last month, for the first time in Uganda's history, they successfully separated conjoined twins. And this was a picture during the operation. And I think that is building resilience, that is building capacity, that is building a sustainable service that wouldn't have been built if a doctor had flown in or a surgical team had flown in and operated on those children, or more likely those children had flown to America to get care. So that is a little taste of all the problems that face people when they're sick. It is a little taste of what we try to do. And it's my great pleasure to now hand over to Rosemary, who's going to say, well, this is what we're actually doing to try and tackle that. So I will stop sharing. And Rosemary, I'll pass over to you.
Thank you so much, David. I'll share my screen. So I will start by giving you an overview of pediatric surgery capacity in Africa before I get to what Kids OR is doing. So Africa is a continent that is fast growing with a population of about 1.3 billion people. 50% of Africa's population is actually made up of children. It's estimated that 1 out of 9 children die before the age of 5. And this is 16 times, on average, less for developed countries. 85% of the children in this region will need some kind of surgery in their 15th birthday. What does this mean? It means that if they do not get the surgery that they need, they are more likely than not to die. For example, it's also estimated through studies that 2.6 million children are born with a congenital anomaly, all of which we know require surgery. Now, the highest rates of child mortality in the whole of Africa in the sub-Sahara region that has about 1 billion people. And this is where the need is greatest. This is the place where health systems are least prepared to care for the children in need of surgery. So what am I saying here? In Africa, we have vaccinated our children. We have treated them of malaria. We have treated them of tuberculosis and HIV. Now, what we need to do right now, and what we are trying to do, is complete that journey and provide surgical services for children to live, thrive, and realize their full potential. Our action plan, A Kids All, is focused on Sub-Sahara region. Now, early this year, David gave me a strategy, and he said to me, Rosemary, I need you to turn this strategy into an action plan that would guide us for the next 10 years. Well, we started by conducting a situation analysis for 40 countries in Sub-Saharan Africa, which would aid us in understanding the existing internal factors that influence the development and implementation of a comprehensive pediatric surgery program. So we looked at things as the percentage of population of children in each country. We looked at where these children are most, where the population is most in a country, the mortality rates of those under 5. We looked at the surgical health workforce in each country, etc. This was done in consultation with local surgeons and anesthesia providers, ministries of health, and academic institutions in each country that we went to. We identified gaps and opportunities to respond to each country's needs as much as possible. And for us, we lay emphasis on strengthening the pediatric surgical capacity through training and provision of surgical equipment, because we believe that is what is sustainable. Now, the analysis that we did guided us to make choices, of course, guided by the ministries of health and the surgeons in country, of where we would then go and install operating rooms that will be dedicated for children. Some findings that we found out were 11 countries out of the 40 in this region did not have a single general pediatric surgeon for all its population. 23 of the countries, of the 40 countries, did not have a specialized trained pediatric anesthesia provider. What am I saying? Let me give you an example of South Sudan. South Sudan has a population of 30 million. 42% are children. South Sudan has no pediatric surgeon. It has no pediatric anesthesia provider. Another example is Sierra Leone. Population of 7 million, 41% are children. One pediatric surgeon and no pediatric anesthesia provider. Now, who is caring for all these children? We passionately wanted to intervene to help these countries that really need our help create sustainable, comprehensive surgical programs so that when we are gone, they'll be able to continue providing surgery to their children and safely. So our 2030 action plan that we developed, in summary, what does it include? We are going to do installation of 120 dedicated operating rooms for children. We'll provide an estimated 87 scholarships for pediatric surgery. Training will provide scholarships for pediatric anesthesia. And let me go back to the operating rooms. The 120 operating rooms have already been identified in the action plan. As we are right now, we know in the 40 countries, each and every hospital that will go into and install the operating rooms. This was part of what we did in the situation analysis, and of course, in consultation with the in-country people. We've also said we are going to provide 87 scholarships for pediatric surgery training. Priority, of course, will be given to the countries that I have mentioned that do not have a single pediatric surgeon or have very limited numbers. The same for pediatric anesthesia providers. We will develop an e-learning platform for pediatric surgery and anesthesia. I must at this point emphasize that this will be the first Pan-African collaborative e-learning platform developed by 2 continental surgical colleges. So what am I saying here? Local surgeons developing e-learning platform for their own people, clearly a bespoke teaching resource. We'll also provide ongoing training for biomedical engineers in the local hospitals so that they are able to maintain the equipment that we supply. We will continue to do extensive research that, of course, will drive improvements in quality, service, and care for our children. And of course, advocacy that will influence policy formulation. What have we done so far in the region? We have equipped 29 operating rooms and 10 currently in progress. This year, as much as we had COVID with all the challenges, we have been able to provide 10 pediatric surgery trainees with scholarships. We have already initiated the development of the e-learning platforms, and I'm happy to report that they are now on their second module. The surgeons are really working hard and excited to see this as a reality. Our data collection from the installations we have done so far of the 29 operating rooms that we have equipped show us that we have been able to reach out to 30,000 children with life-saving procedures. In advocacy, we have vigorously engaged the ministries of health through regional and intergovernmental organizations, and slowly we are seeing countries include children's surgery in their programs and policies. So this is a typical Kids OR theater or operating room after installation, dedicated for children. As you can see, the pictures, it's child-friendly environment that is not scary for a child to be in, as is with ordinary theaters. And for us, we know that safe surgery is not possible without adequate equipment and supplies. And we are making this a reality in as much as we can. On your screen, you'll see a graph. This is a graph showing what happened in one of the 29 installations that we have done. This is at the Muhimbili National Hospital in Tanzania. What you can see is the annual pediatric surgical volume. And you can see in 2017, with the introduction of our kids operating room theater, after 1 year, we see that the numbers of the volume of cases has doubled. So what is this telling us? Surgical procedures increase exponentially because this model is working. Children no longer have to queue with adults to get an operation in the same theater. We know that even though a child needs an emergency procedure, and a pregnant woman comes and she needs an emergency, of course, cesarean section, the child will be put aside regardless. So with these dedicated operating rooms, our children are able to get services faster. The caseloads that we know in Africa date back to years are getting reduced exponentially. So the impact is apparent. Deaths and disabilities, we can say, are being prevented, and this model works. On your screen, you'll see pictures of the pediatric surgery trainees that we have sponsored 2020. This is very exciting for us. What does this mean? Once they complete, it is estimated that in Africa, just one surgeon does about 400 surgeries per year. So if you count a number of 10, you can see how many children will get access to surgery, how many lives will be saved and disabilities prevented by having these people get the right skills. This is the impact of the scholarships that we are providing and we seek to continue to provide. So we take a horizontal approach in this region. We are not only looking at one component. We are looking at a comprehensive approach. We train surgeons, we give them the right tools, and they bring in the impact. We know if we give trained professionals that you can see here the right tools, then the impact will be a very big smile. And on my next screen, on my right side, you will see a little girl who is 3 years. Her name is Tamandani, with a big smile. And on my right is one of our partner surgeons called Dr. Nandi. I'm going to give you a little story of Tamandari. This is a case, I will say, of a girl saved with the right equipment at the appropriate skills and at the right time. So 3-year-old Tamandani was eating roasted corn when she accidentally inhaled a corn into her lung. She suddenly couldn't breathe properly. Her parents raced to get her to hospital. By the time Tamandani arrived at the hospital, she was fighting to breathe. And just before she reached the operating room, she stopped breathing completely. Tamandani is alive today because Kids Operating Room provided a piece of equipment called a bronchoscope to Dr. Nandi, you can see on your left, and his team at the Kamuzu Central Hospital in Lilongwe, Malawi. The bronchoscope enables Dr. Nandi to see the core in the lung and pinpoint and remove the maize kernel. The operation, I'm happy to say, was done in our Kids Operating Room installed theater. Today, Tamandani is alive. She plays, she sings, her family is happy. Many children in Africa are not lucky like her. In similar circumstances, they die. These deaths we can prevent because no child should die or live a life of pain or disability because of a surgically treatable condition. Now, children don't sit in policy-making tables or budget formulating tables. Children only cry in pain when they can't get the service and care they need. We are their voices, and we need to act to ensure the children get access to surgery when they need it. Over to you, David. Thank you.
Rosemary, thank you so much. That's perfect. I think that often something people say is, well, how can we get involved? And we do rely currently on clinicians from 9 Wells supporting us, helping us assess equipment, helping us to identify what should be in each operating room. And even this morning, I was talking to Dr. Grant Rodney, who I think is here today, about exactly that. So there are always opportunities for your clinical skills to support. There is also the simple reality is that, like every organization, we do rely on financial backing, and we believe it costs about £50 to provide each operation. And anybody who simply wants to support that way, we're very grateful for that. And failing all of that, we would love it if you followed us on our social media pages. And then you can at least continue to see the journey. And I think this week alone, we had a shipment leave for the Democratic Republic of the Congo. And then we had another shipment leave Dundee to go to a refugee camp in Kenya. That will create, in partnership with the UNHCR and a foundation called the Biltema Foundation, will create the world's first ever dedicated children's surgical service for a refugee camp. So there's some pretty exciting things happening out of Dundee, and I hope that today we've given you a little flavour of why we do what we do in the way that we do it, and also what we do.
Thank you so much to you both, David and Rosemary, for such a fascinating talk. And I'm sure there'll be some questions. If anybody does have questions, if you want to put your hand up, if you know how to do that on the screen, or if you want to put a question into the chat, I'll pick that up and read that out as well. But if anyone has any questions, please go ahead. Mudir, I can see your hand up. Oh, that's a clap. Sorry, it's not a raised hand, it's a clap. I'm struggling to hear you, Mudir.
put that in. I said it was a round of applause for the impressive work. I was going to raise my hand, but I thought I'd give other people the opportunity first. But if there's nobody that's raised their hand, I can ask if that's okay.
Go ahead.
Yeah. So just really a special message to David and Rosemary for the impressive effort and work that you guys have done. It'll be known to some of the group here that I've been involved in quite a lot of similar work in Iraq, my country of origin. And I mean, to be honest, a sort of 20-minute, half an hour presentation on this doesn't give it enough credit. I mean, it's just unbelievably complex logistics to do what Rosemary and David have been able to do. Honestly, big hats off to you guys. I've got a couple of questions, if that's okay. One to David and one to Rosemary. So David, I'm just wondering about something that you mentioned about geographical inequity, especially when they're having to travel 2 or 3 hours to get to healthcare services. Has anything like sort of subsidized ambulatory care been taken into account that would allow these people to be able to, if they're going to be traveling long distances, at least when they get back, they might be able to have some stuff for them in their rural community? So I'll give you an example. That something that I was able to do in Iraq was, for example, if I have somebody with a COPD exacerbation, then we could give them on loan subsidized nebulizers, oxygen concentrators that they can plug in, accounting for what generators they have and what power cuts they might have, etc. Something similar to this, for example. And regarding any sort of way forward with public-private partnerships to try and help, again, with some of the healthcare inequality and incentivize the doctors there. And Rosemary's question was basically the pediatric scholarships. I'm really sort of intrigued and interested of who's going to be overlooking that, and are they getting scholarships from abroad? Is it in Europe? How much of it is virtual? So these are the 2 questions. Thanks.
Great. Well, I think that first question's really interesting because in some countries we're able to move that type of service forward. So in Malawi, for example, there is a project just now that recognizes that I think something like 85% of surgical care is provided by clinical officers. And so it is about connecting rural hospitals with the consultants either in Blantyre or the Longwy. And it is around developing referral networks and what can be provided as that sort of front line of care, and then what needs to be sent in. So it's about training, it's about basic provision of equipment, and then it's about successful referral networks, and also then logistical support to physically get a child from a rural community perhaps into Blantyre. So there are countries in sub-Saharan Africa where that type of care is starting to be developed. There are others, as Rosemary said, there are 11 countries that have absolutely no surgical service for children at all. It just doesn't exist in those countries. And what we're doing, I mentioned Burundi a couple of times because that's a particular interest of mine, because that's one of those 11 countries. And although we have now awarded 2 scholarships, and 2 Burundian surgeons are now starting the 3-year pediatric surgery fellowship training, we feel there is an opportunity to start surgery for children in Burundi in a more comprehensive way. And so we are now starting to explore what specifically in Burundi are those barriers to care. And so that 3 years from now, which seems a long time, but actually, there's never been a service for children, but 3 years from now, there will be. And Burundi's not that big. It's problematic because of its terrain and its infrastructure, but it's not, it's not a huge country. Then we're starting to then plan how, exactly what you said, how do we put in place that ambulatory care? How do we, if you have a child come in and maybe has a stoma put on and then is sent home, that family needs support and
Yeah.
care. And so how do we engage community health workers in that process and make surgery much more a sort of primary healthcare service? So some countries are ahead of the game, others are definitely not, but I think there's a sort of recognition that exactly the things you spoke about need to be developed. And as to whether there's a role for the private sector, I mean, always, but our work will always be in the public sector. And so there needs to be a willingness to come and support the strengthening of the public sector. Yeah. Rosemary?
Thank you for the question. Very interesting question, and happy to respond. I'll say this: what we are doing, we building local capacity so that it's sustainable. I kept repeating that statement. So when we provide this pediatric surgery scholarships, we are doing it through the local colleges. There are two colleges that we are working very closely with. This is the College of Surgeons of East Central Southern Africa and the West African College of Surgeons. So we get these trainees to train in that training program. If a certain country, of course, is accredited by the training college, then they are able to train in their respective country. But these 11 that we mentioned earlier that do not even have a single pediatric surgeon, it basically means that they do not even have a pediatric surgery training program. So what we are doing is, for example, in Burundi, what we did, we got 2 pediatric surgery trainees who were very interested and moved them to Malawi. We moved them to the same region in a facility that has a training program accredited to train with qualified senior surgeons. So for us, we do not take them abroad, but we can rotate them within the region so they keep serving their own people. And one of the things we have done as a commitment before we provide any scholarship, they have to commit to go back to their country. If we take you to Malawi, we expect you will go back to Burundi, because we took you there because we know Burundi has a problem. So we want you to go back in Burundi and serve in a public facilities where we know the need is most for the years that we supported your training. So if we supported you to train for 3 years, we expect you to go back and serve in a public facility first for those 3 years. That is the way you give us back that grant. And of course, in that way, we are able to reach out to many children. So that is how our scholarship grant is modeled. And then further to say that our scholarship grant is sufficient to ensure that a pediatric surgeon is not struggling. There are many people who would want to engage, in specialist training, but the funds are not there. The training is expensive. So we remove that burden from them so that they can concentrate and train well, so that they go back and serve the children of their nation. Thank you.
Thank you.
Thank you so much. A question from Peter Mossy.
Yeah, let me open up my systems. David and I know each other anyway, and I was very keen to ask a question related to opportunities to establish sustainable links with our university here in Dundee. And I think one of the features we've discovered in the University of Dundee is that we have a quite significant array of University of Dundee alumni who are back in Africa in various parts across the country, and whose expertise may not be confined to medicine or anesthesia or surgery, but a whole range of other maybe disciplines and engineering and architecture. And we know that these problems, and was mentioned earlier, are not single, they're transsectoral, they're multidisciplinary. And there is perhaps value, or I'm going to ask the question, in looking at our alumni in Africa and asking, can they contribute or assist with this multidisciplinary and transsectoral approach to providing surgical care? And related to that, I was just going to ask about research, and I think David mentioned, and Rosemary as well, the desire to ensure that quality improvement and research is a component part of your operations. And therefore, would there be opportunities for the large research focused University of Dundee to link in and contribute?
Well, maybe I'll take that one, Rosemary. So thanks for that. I think that on the first point, you're absolutely right. The alumni network is powerful, and I think that if we can use that to help in different countries highlight the challenges that exist within children's services, fantastic. If we can use it to help bring solutions or help us to navigate the Ministry of Health, for example, then fantastic too. So I think there's lots of opportunities to collaborate there. On the research, we do have a formal research partner, which is the University of California in San Francisco, with a secondary partner being the University of Oxford, and all of our research is coordinated through them. And I get asked by a lot of universities if, sort of opportunities to get involved. And I tend to always say, oh, unfortunately, that's slightly a closed house. However, the door is always open for the University of Dundee, as far as I'm concerned, to be involved in what we do. And so I would certainly explore how that might be possible, which would be excellent. So yeah, for sure.
Thank you. A question on the chat, apologies from someone who missed the beginning, who says theatres are expensive. Where is the finance from?
We were originally funded by our founders, which is Gareth and Nicola Wood, and they put substantial funding to establish Kids Operating Room. And they were very clear that they did not want to launch an idea. They believed this was an effective intervention, but they wanted us to prove it first. And so we did. And I think, as Rosemary alluded to, we're just about to cross 30,000 children. I think that's pretty good evidence that this works and is effective. But we're now transitioning to a phase whereby we are bringing in external donations, just like any charity. And so at the moment, almost all of our funding now comes from, certainly going forward, comes from external sources. Gareth and Nicola were phenomenally generous to establish us and still house us in our Edinburgh office is in a building that Gareth owns, and still provide a tremendous amount of support. But our plans going forward are to bring in external donations, and that's proven to be pretty successful.
Thank you. I can't see any more hands up. So I'm going to ask a couple of my own questions, if that's okay. My experience is from supporting anaesthesia training in Zambia, and so I can only imagine the complexities around trying to support surgical services in 40 different countries with 40 different Ministry of Health and different cultures. I can only begin to imagine. My questions, I've got two which are loosely around sustainability. The first is that I have learned that it's very easy to measure quick fixes and things that don't take long to do and have short-term goals, but it's much harder to measure what I think is the more important stuff, which is the slow burn stuff, which is the advocacy for specialties, the capacity building, the influencing and negotiating with ministries of health. So while I can see it's relatively easy to measure how, you know, the number of theatres installed, the number of children that have gone through in a year, how do you measure the slower burn stuff, the long-term stuff, the stuff that probably really matters?
Well, I'm happy to have a go at that, but also, Rosemary, I'll welcome your input. I think Uganda is a really good example. It's the country we first started in. And when we first went, there was one paediatric surgeon. There is now a Ugandan Pediatric Surgery Society, which was unimaginable. I think that there are things like that take it from being almost non-existent to being an integral part of the health service. And I think that we get to a stage where we look at Uganda and say, realistically, we may only need to do 2 or 3 more projects in Uganda, and then actually there is sufficient infrastructure. They will need more people, they will need more training, obviously, and when I say people, I don't just mean surgeons, obviously the whole surgical team. But I think that this is an intervention that can have an endpoint. And so for me, when I look at the wider picture, I look at nations that have gone from either no surgical service for children or absolutely, you know, very, very fragile, 1 or 2 people, to it being an integral part of the healthcare system. And when I see ministries of health picking up the funding, employing more people, taking it on as if it was just part of what they do, for me, that's the sign that it has worked.
To add on to that, advocacy, as we know, is a process. And we have vigorously, like I said, been engaging ministries of health and intergovernmental organizations through, you know, their networks to ensure that children's surgery is included in their policies. And like I said, slowly we have seen this happen. Ministries of health come, they meet their presentations, they see the magnitude of the problem, and it's included in a resolution of that meeting. So that for me is also a measure. It's something that the countries will be told to implement. And we have seen fruits recently because Nigeria, for example, its national surgical obstetrics and anesthesia plan has actually included children's surgery. And this is a national plan, so quite measurable. And this is, once it's in the national plan, what it means is that the respective country has to budget for it.
Thank you so much. It's always an ongoing challenge in my head. The second bit of the question is probably easier. Is installation of equipment and bringing equipment to somewhere that hasn't had it before. How do you, so you have these beautiful theatres, how do you ensure that they are maintained and that they last beyond the first few weeks?
Well, I can give you some answers to that, but I also see on this call is some of our Dundee team, and Dave Tipping there, who's waving, is our Director of Global Operations. And so he's sitting in Dundee just now and is responsible for all of that. I'll give you a couple of things, and if Dave wants to add anything, Dave, please do. So first of all, that's a huge issue for us. What happens if we leave on the Friday night and on the Saturday everything gets, you know, taken out and redistributed within the hospital and various things. So we employ a data collector at every hospital we work in, and that allows us to monitor what's happening. Is it being used? And if not, we can quite quickly ask why not. We have we engage with the local engineers, and we have a mock operating room in Dundee. So you know, if you ignore COVID, at any time, any of you could go and visit just in Dundee an exact replica of one of our operating rooms. And that allows, so an engineer could call into our engineer in Dundee and say, I'm having a problem with this bit of equipment. And he could stand in front of the same thing and say, well, this is, look what I'm doing here, and show me how it works there. So we can provide that kind of support. But we do also do inspections. And so we will do both announced and unannounced inspections, where we will literally just appear at the door one day and come in and inspect the equipment, review what's there, is everything that's there that should be, is it being used, who's on the table when we arrive, you know, is it a child through the public service, or is it an adult that's paid to get in? We do that, they know we do it, they talk about it, and I think that all helps in terms of making sure that the equipment continues to be used for the people that it was meant for. And if anything breaks, then we can replace it, we can support it getting fixed. And we can usually tell something's broken because the data tells us that a certain thing isn't happening. Dave, is there anything you feel add to that?
Yeah, I'll add a few points there. So I think there's probably three main things. First thing is in general, it's all new equipment that we provide. So it's all tested here in Dundee before we ship it out. We provide training and testing at the other side as well. So right now, typically we would travel out to meet the equipment at the other side. So my team here will go out and set that up and hand it over. Even with the COVID restrictions, we've managed to find in-country engineers. We're in the process of training 4 of our own engineers which cover sort of each region of Africa. But I think the first one is really, the equipment we provide is tried and tested. We do get feedback from that. We're constantly renewing that and updating it, but it's robust new equipment that we're providing. That definitely helps. The second one is really relationships. So as much as Rosemary will have relationships with ministries of health and more strategic things, myself here and engineers form relationships with the teams in the hospital, and that includes their engineering department. Now, it varies hugely from site to site. Some engineering departments have all the latest fluke test equipment and they can carry out the installation themselves with a little bit of guidance. Others don't. That's sort of part of our network we're developing, is to make that test equipment available to all of the hospitals that we have. But we have ongoing relationships, so it's not uncommon. Even at the weekend, you'll get a WhatsApp message from an engineer with some pictures, and that's just something that we deal with here. And I think, yeah, the third thing really is that moving on as we get more projects, as we have, eventually over 120 rooms of equipment out in Africa, is very much part of our strategy to train local engineers as well and give them the correct equipment that they need to continue to look after the equipment that we provide. So yeah, I think that's probably touched on all the things. We do monitor, we monitor its use, we form those relationships. It has been a bit of a barrier because often the hospitals will be sort of almost ashamed to admit if something's broke. You've provided it for free, and it can be almost a cultural thing where they can't tell you. So we found that out from doing some of the early sort of inspections, but it's just something that we really hammer in now to say it's no use to us to provide this equipment. When it breaks, accidents happen, and it's pointless not doing what it needs to do. So just tell us and we'll resolve it. And I think on that third point as well, as David said, we're not just about supplying the equipment and walking away. It is that relationship, and it is that ensuring if they need spare, we provide spare parts, we provide guides, these sorts of things. But if something breaks, we will work with them to resolve it and get that fixed as soon as we can, to ensure the room's working as it should.
Again, thank you. And it's nearly 2 o'clock, so all that remains for me to say is a huge thank you to both Davids and to Rosemary for the fascinating insights into the work that Kids OR is doing. Thank you to the rest of you for joining in, and as ever, the talks are recorded and put onto our YouTube channel, so if you miss anything or if you'd like to see some old ones, you'll find them over there. I think next week, Professor James Chalmers talking about his recent work on bronchiectasis. Is there anything else that we need to add into that?
No, he's going to talk about the unpronounceable
I wasn't going to
brensocatib.
try.
Yeah, brensocatib, a novel treatment for bronchiectasis, which he's also been leading an international trial of in COVID. So it's cutting edge stuff done here in Dundee by my pal James. I'll go and remind him.
All right, so thank you so much again to all of you.
Thank you.
Thank you.